Welcome to the Friends of NPACE Podcast, brought to you by Haleon. As a leading global consumer healthcare company, Haleon is dedicated to delivering better everyday health with humanity. Known for trusted brands like Advil, Excedrin, and Voltaren, Haleon leverages science, innovation, and human understanding. Haleon is proud to collaborate with NPACE to educate healthcare professionals about our pain portfolio and the latest healthcare information. For more information, visit www.haleonhealthpartners.com.
Welcome, everyone. We're back for another episode of the Friends of NPACE Podcast, and we're in our APP student mini-series. You know me, I'm Terry Schmidt. I'm a nurse practitioner and the executive director of NPACE, but I am, again, very excited to introduce a guest who is near and dear to us, Dr. Efrat LeMandre. Dr. E, you're the
Hi.
NP. You're the NP with the PhD,
That's me.
best-selling author. What book is coming out next?
It's about medical gaslighting. Yeah.
That's going to be amazing. When does
Yeah.
it launch? Like when
It's
can
coming
we
out
get
in
it?
It's coming out in 27. So we'll have another
Okay.
podcast before that happens. Don't you worry.
All right. Well, that's because you're a medical disruptor,
Yes.
disrupting, reshaping healthcare. You own and operate EG Healthcare. You're representing, which I love. I'm representing today. Very nice. And EG Healthcare is also a practice, right? 20,000 patients across the life
Yes.
family, right? Peds
Yep.
to Gero. Okay. You also, you're a problem solver because we talked to you during Entrepreneur, Hawk Scribe, medical scribe company.
Yep.
And the other thing you found in your practice is you're spearheading nurse practitioner education. I would say all APP education, everyone could use this, or people do in practice, but we just talked about some specific deficits in NP
Yes.
education, how we teach, and EG prep. That's what we're here to talk about.
Yes. We're talking about EG prep today.
We are talking about EG prep. So tell me what EG prep is and why you started it.
It's a really good question. Thanks for that. First of all, thanks for having me. Anyone listening, NPPA. For those PAs out there listening, my wife's a PA, so stay tuned because it's awesome. And she's part of EG prep too. She's the G in EG. So we are like our marriage, very similar to NPACE. It's about putting NPs and PAs together. So everyone stay on board. So thanks for having me.
That was a great off-the-cuff annagy.
Thanks. Our marriage is like NPACE. My wife will be that's so romantic, love. But I think it is what NPACE is doing is really important, being there for all APPs, not just NPs. And I think it's wonderful because we all need to stand together. So thank you for doing the work that you do.
Thank you. Thank you for joining us.
Of course. So as you said earlier, I own one of the largest nurse practitioner-owned primary care practices in the country. And we see full patient calls, pediatric, adult, we have house calls. And, a lot of through the years, a lot of NP students rotated. We also thought that also about mentorship, rotated through our hallways. And what I kept seeing rotation after rotation was that there was this gap. There was a gap, really smart, well-prepared students who knew their material, but then they completely froze when a real patient sat down in front of them. Right? So there's an enormous gap between what they learned in school, and they could be straight A students, passed their boards, but there was this gap between what they learned in school and what actually happened in the exam room. So we started developing like a process internally to help mentor them, help them through it. And what we discovered is that there's really cool things that once the students learn how to really chart the HPI well, they also learned how to treat it. So the charting wasn't just documentation. It started making the clinical reasoning visible. We'll talk more about that in a second. So we really leaned into that. In fact, when the students came, I used to teach them how to chart first, and then we'd back into the diagnosis later. Mm-hmm. And we noticed that we actually use that to teach our scribes later on. So we started doing this locally, just to our students, and then the word spread, and then a local university picked us up, and another one, and now EG Prep is a national company, and we're everywhere. I mean, we're in Clinton State University, we're in Ohio, we're at Yale, and we just are also international, and it just shows that it doesn't really matter the institution that you're in. So there's like no shame if you need this. This is how currently the NP curriculum is delivered. And as wonderful as it is, it does have a gap, and EG Prep helps to solve that gap.
Yeah, one of the things we do is we teach health assessment, right? In this separate course as this body system thing with documentation.
Yes.
And we don't combine it with how patients present, and that HPI, that history of present, it almost seems to be like a separate thing. And then we go through and teach diseases by age group and gender.
Yes. And this is specific to NP curriculum. So for those PAs listening, this might seem rather surprising, but specifically for NPs, there is this gap around how to build the HPI and how to incorporate differentials in there, and incorporate the red flags in there, and using that HPI to show your next steps. So it is something. There's definitely a gap in the curriculum, as you suggested.
So all the students learn this. Give me an idea of like what the approach is. If someone comes into EG Prep, like, is it based on complaint? Are you focusing on differentials?
Yeah, it's a great question. So the premise is that we are not going to reteach you everything, right? And nor do you want to learn everything, right? So
no, thank you.
No, thank you. So the premise is you already have a great education. Your professors did a great job. So what we want to do is teach you a system that you can use every patient every time, even if you don't know the diagnosis. That's really important because sometimes you don't know, right? Sometimes that patient has an abdominal pain and they need a scan. You don't know. What you need to determine is if they can be managed outpatient or if they need to go to some sort of escalation. So what we've done is we took the most common chief complaints. It is for primary care or women's health. There's pediatrics as well, pediatric primary care, right? This is not for inpatients. So it's the chief complaints. And then what we do is the very first thing we do is we go through the red flags for that chief complaint. So we have to, right away, you have to know a headache comes in, here's the red flags. And by the way, at the end, we also give you a PDF of all these things. We want you to copy paste the things. So here's the headache, red flags you have to watch out for. And then we go into the HPI for a headache, specific for headaches, because there are certain sentences and certain questions that must be there for headache, right? That are different than for back or for chest pain. And we want you to take the HPI, we literally want you to copy paste it, because we know that if you copy paste it and then ask all those questions to make it personalized to that patient, you can't lose. If you made sure that that's not the worst headache of your life and you put that in there, if you made sure that the chest pain doesn't worsen going up the stairs and that you put that in there, then by the time there's a formula which I'll get to in a moment, but by the time you get to deciding whether they can, go home with a Tylenol or go to the ER, even if you're not sure what it is, by that time but if you ask those questions, you'll already know what to do at the end.
Nice. It's a safety net.
It's a safety
logical.
net. It's a logical clinical reasoning. You have your red flags. You have your HPI that's specific to the chief complaint, and you have a physical exam for that chief complaint, right? So make sure if it's a headache, don't forget to do that neuro exam, which it's not, very well that a lot of people forget to do that. And so
what's a neuro exam?
What's a neuro exam? I never heard of it. Yeah. So if you have this, so now you are going to, after you're done with the module, you have this PDF that you take with you. We want you to take it to your rotation. We want you to take it to your first job. We literally want you to copy paste it. You can't go wrong. And again, the key component is you don't have to be the one to figure out what it is. Sometimes that happens later with experience. What you really want to do is be able to sort outpatient appropriate versus escalation, because that's the stuff that's going to get you in trouble in rotation or in the beginning.
And that's what they're going to look for if your charts ever get subpoenaed or patient posters or break. I like this approach. I'm thinking of analogies in my head. So when you learn to read a chest x-ray, you read it the same way, right? Every time. No matter if you open it up and there was this giant black blob and you're like, well, that is bad. But let's start at the beginning. What do the outside tissues look like? Can I see all the ribs? Is it rotated? And we learn that for everything, right? How you look at a blood count. What's their H&H? What are their platelets? Yes, things may be, but start there. It's almost like that. For chief complaints, same way. EKG, right?
EKGs Exactly right. It's
Read
exactly
them the
right.
same way every time. Follow the
Ex-
same thing.
exactly. That's what we want to do. We want to make it like primary care for dummies. And and I hate to say that because of course there's nuance and of course there's exceptions to the rules, but a lot of times when we keep surfacing those, the anxiety for students gets overwhelming. Like, how do I miss this? How do I miss this? When we talk about the zebras all the time. So we came up with this formula. So after we teach you the HBR and the physical, we ask 4 questions. You got to look at HBR. Are there any red flags compared to the red flag list? Okay, no, great. Next, if there is, you send them. Are there
Okay.
any red flags in the physical exam? Because sometimes the patient can be like, oh, nothing's bothering me. My wife told me to come here. And meanwhile, there's this big, huge hole in the back of their head, right? So,
Right.
so we don't
I
always
don't
just
know
go
why
back.
I'm here.
I don't know why I'm here. Meanwhile, their fingers like this, oh, my
Yeah.
crazy wife, right? I don't know why I'm here. And their face is falling off. So it seems silly to say, but you have to first, and vice versa. Sometimes the physical exam looks like nothing, but the
Amazing.
patient's telling you, especially with something like a headache, like yesterday out of nowhere, I had this headache and then I threw up and then I felt better. Now I feel great. I don't care. You're still going to the emergency room, right? So there are 2 distinctly different questions. Are there any red flags in the HPI? Are there any red flags in the physical exam? If that's a
Okay.
yes, we stop and we just send. Don't know what it is. They're going to need a scan. They're going to need troponins. Not sure, but I'm sending. And then the question is, do the HPI and physical exam align with each other? And that's kind of the same thing. Like if I have one here, but not here, do they align? And then is the HPI complete? If you didn't actually copy my HPI that I gave you for headache and you decided to wing it, and that's how you decide there's no red flags, you're leaving yourself open, right? Because some HPIs are bad. So take a look at that HPI you just wrote and see, did I really ask every single question in this HPI? Because sometimes we do it purposefully, like we'll ask and we'll skip, and they're like, yeah, there's no red flags. I'm like, yeah, but you didn't ask, I don't know, bowel, bladder, incontinence for back pain.
Right.
Yeah. So those are the 4 questions that you ask after this. So you have your red flags, you have your HPI, physical exam, 4 questions, and then you just apply that. Then we give you case study after case study after case study. And if you just do that and you take that and you just repeat it again and again and again, at the very least, you will never miss an emergent situation.
I like that. I like that a lot. And then you can start backing into differentials and
then you back into
from the
differentials.
statistics.
Yeah.
Interesting.
But that's the biggest thing for especially people starting out, is like, is this chest pain a heart attack? Is every chest pain a heart attack? is every headache a stroke? Is every headache, right? So that's the thing that scares people, and then they don't know how to back into it. And if things get worse later, that's the other piece of it, right? Like, how do you prove that when they were there with you, they were fine? And the way you do that is because look at this HPI, look at this physical exam. Stellar. I asked all the questions. So 24 hours from now, they deteriorate. It also protects you.
They looked good when they walked in the office, and here was how they answered all the specific questions
Exactly
that I
right.
asked.
Exactly
Yeah.
right.
How long do you think students need to practice this before the light bulb goes on? I'm sure it differs for every student, but it's completely different from bedside nursing, right?
It's different bedside nursing. I have to say that I still practice this way. Like my HPIs are exactly the same. I ask the same exact questions all the time, just as I ask my screening questions for age 40 and 45 and 50. Like there is, I do old carts in my head every single time I talk to somebody.
Yep.
Like I don't see a world where you step away from that. And I think what expertise is like when it becomes, you don't even notice repetition anymore. And then you could have room for more nuance and then and asking or finding exceptions. But it's a forever thing. Don't you think so?
Yes. I saw patients on Monday night, and the first 3 out of the gate, I'm like, I promise I practiced 25 years, but we need to continue this second visit while I consult greater minds.
Oh, that happens to me all the time. I love that you brought that up. It's unrelated to EG prep, but one of the best things you could do for your patients is to say, I don't know, let me consult with somebody. So please, don't let hubris stand in your way. I consult all the time. Sometimes I call up my wife. Sometimes I get a quick consult. I'm like, baby, look at this EKG and tell me what's good. Sometimes I call someone on my referral list and say, I'm not sure about this guy. I don't think I want to send him to the ER, but can you see him tomorrow? And sometimes I call for consults, but I think that's super important to, I think that shows a great clinician being able to ask when you don't know.
Yeah. Well, I do it a lot, so
Me too.
I must be a really great clinician. So
stupid. That was funny.
Well, you're welcome, patients. How long does this take a student at first? Like they get your stuff, they're familiar with it, but we send them in with the first patient and say, go in here.
Yeah.
This person's in here today because fatigue. That's a great one, right? Here
Fatigue's
we're
a
gonna
good
work.
one. Do I have one for fatigue? I don't know if I have one for fatigue, but I should do one. But we have one for dizziness.
Yeah, you know fatigue better than anyone else. You should do one for fatigue.
That's a little more functional medicine, but yeah.
Yeah.
Yeah. But we do. So let's just say dizziness. Dizziness is a good one. People hate dizziness. People like get very nervous when it comes to dizziness, right? Like vertigo versus anything, you know? So it's a 1 hour module. You watch it, and then we don't want you to memorize. I don't even want you to take notes when you're watching. I just want you to watch it and listen to the concept. And then I want you to download the PDF, whether it's on your phone or whatever. And tomorrow, I want you to do, on your first dizziness, I want you to take out that PDF and just look at that HBI and ask the questions. That's it. Do you have this? Do you have this? Do you have this? Is the room spinning or are you spinning, right? Is there any nausea or vomiting? And then I want you to go and be like, oh, let me do the physical exam, which I'll tell you exactly because you're going to know what to write. And then every time you're going to look at that red flags list that's in your PDF and be like, do you have this? Do you have this? Do you have this? And then you're going to be able to go. And that's it. That's all I want them to do, because I know, to your point, if they just keep doing that, eventually it becomes memory. So I wanted to take, even though it's clinical reasoning in a sense, but I wanted to take that need to constantly pull information from a lot of sources. It's a lot in that first year.
It is.
It's just a lot.
So much.
Yeah.
And we don't teach that way. We do, here, this is your pulmonary module. We're going to learn about COPD and chronic bronchitis and asthma and all the steps of asthma. And also we're going to learn about pneumonia and blah, blah, blah. It's not cough.
Exactly right. That's exactly right. Thank you for saying that. So patients don't come and say, I'm having a COPD exacerbation. They're like, I'm having a cough. And you have to figure out if it's a COPD exacerbation. So something as simple as
now
cough.
they have a new onset CHF, right?
New onset CHF, exactly.
We don't teach that in the pulmonary module. I'm so sorry.
No, that's exactly right. And I don't think that we necessarily teach that if they came back to you a second time coughing and 6 weeks have passed, it's time for imaging, right? So I think there's a lot of things like real boots on the ground stuff that we're not teaching. We even have a module called sore throat, and I can't tell you how many NP students like sore throat. I mean, strep versus viral. I'm like, hello, what? Like sore throat could be so many things, some of which could be life-threatening. So being able to go through that. So very few people come in and say, I'm about to have epiglottitis, right? They're saying, wow, my throat really, really hurts. So that's why we go. It was a really good point you brought up, because it's about the chief complaints that they're probably going to see, as opposed to we're going to discuss the pulmonary system today. Yeah. And
that's exactly how they come into the clinic. That's how they schedule appointments. That's what used to be in the olden days, written at the top of the chart. Yes. That's what, dysuria, vaginal itching, cough.
That's exactly all you're going to see. That's exactly right. So we have one for irregular bleeding, because you have to figure that out. Menopause is a great one too. I love the menopause one. It's set up a little different because not too many red flags in menopause, but we do need to start knowing when our patients are in perimenopause so that we can not tell them that they're crazy.
I'm only chuckling because I bet everyone that knows them could tell you.
Yeah.
There's something wrong with
Something's wrong. Something happened to my mom.
Exactly.
That's exactly what
my
right.
children said. No, I love this. And the reason I chuckled about the pulmonary one is I one time worked in this group of physicians, and there were 11 of them. They were phenomenal back in my early NP days. And one of them kept treating himself with, we had a closet then of meds, right? Samples, and with an inhaler, and he was just having difficulty breathing. And one day he's like, it was the olden days. We could just walk down the hall and get a chest x-ray, right? It was all in one building.
Yes.
And what do you know? His heart was giant.
Oh my God.
He'd gotten viral cardiomyopathy probably from one of the patients. It was a pediatric vet, but he just treated his shortness of breath with that inhaler forever.
Oh my God.
Seen anyone. I'm like, well, that's great.
Wow.
Red flags of shortness of breath.
Yeah, not responding to albuterol.
Exactly.
Don't know why this is not working. Let's get a new pump.
Exactly.
Oh my God, that's so funny.
I have a philosophical question, and I'm
Okay.
asking it to you because you're teaching in this method. Do you think it affects student satisfaction in how they're learning and what they're capable to do, and maybe even in future employment, by learning in a way that makes sense, as opposed to trying to sift through all of this disease information that they have?
Are you saying that once they see this, are they going to look back at how they're being taught?
Yes, or just have more enjoyment, less fear overall, like more
That's my
satisfaction.
goal. My goal, and the way while certainly individuals can use this, and certainly you can come through NPACE at any time. We're partners, and you can find us on their website. But universities that work with us, I encourage them to start EG prep as soon as the students go into rotation. So they learn their didactic, their 3 Ps, as the NPs like to call it. And then they're going into rotation. And this can, in my opinion, make or break a rotation, because you can just be a fly on the wall and just watch.
Mhm.
Or you can really get in there, but it's terrifying to do that. And this tool can make you, like, if you're lucky enough to have a mentor, is like, go in the room. This can really you can really feel like you are doing the thing while you're in rotation. And I know that you're doing it well, and coming back to report to your mentor and say, okay, this is what I saw. These are the red flags. Here's my HPI. Here's my documentation. And they're going to say, great job. And if you can do that in every rotation, we usually align the module that they get based on, like, if they tend to do women's in one rotation or peds in one rotation. So
nice. Yeah.
And then, and our hope is that by the time you graduate, you have this stack of PDFs that you will then take with you to your new job and put it in the templates.
I think that's brilliant. In OSCEs, and thinking about OSCEs and checking out students that way and what they could do, this is what they struggle with the most, is how to go in and really gather the information. Like, a history is the most important thing you can get. With a physical exam is very important, and the tests are important, but how you gather what patients tell you.
Yeah. What they tell you versus what you need to hear. The gathering information is the hardest skill. And I don't know that we do it enough in NP school.
I agree. And I know they're scared of us checking them off and doing OSCEs, but sometimes that's the only way to really, that's why if you have a good clinical rotation, I love that we're learning this way. I love having students because they teach me.
Yeah, the students teach you. And that's the other thing with EG prep, that because of how things are set up with mentors and preceptors, we know that it's an ongoing issue. But not all preceptor experiences are the same.
Correct.
And so you can walk out and be like, oh my God, I'm ready for my first job. Or you can work out and be like, wow, I know how to give coffee. So, right, depending on who your preceptor is, unfortunately. Mm-hmm. And so I really feel that this tool also levels the playing field. Because everyone's going to come out with this information.
I really like that a lot. I told you I would tell you that I loved it, and I love it. What tip would you give, I'm going to say, APP educators, preceptors, and NP educators, if there's one thing that you could say, just do this one thing when you're teaching students, what would that be?
Teach the real world.
I like that.
Yeah, obviously teach them all the didactic first, but then give them real world. Don't always scare with the scare sign. Then they missed the headache and it was really like that. That's not really helpful. Teach the real world. Here's where you're going to see. This is what EG prep is about. The real world. This is what you're going to see. This is what it looks like. This is what you need to do. I think if we did that, we'd prepare them so much more.
I like that. We get busy teaching diseases that are high risk too. Do not
Sure,
miss these things like, I don't know, temporal arteriitis or a
sure,
stroke or
sure.
when we didn't teach a headache differential,
Ah, so
an
true.
exam. So I really like that. What what advice do you give the NP and PA students when they're learning on schooling?
This is the same advice I give to people who want to start a business or want to start a venture. Stop trying to figure it out before you feel ready to practice.
Okay.
There,
Just do it.
you have to start. You'll never know everything. None of us do. I mean, you were practicing for so many years and you just ask questions, but you have to start. You have to get uncomfortable. You have to stumble a little bit. You have to be like, let me go ask. Trust me, patients are, unless they're like real jerks, patients will be like, like the fact you may not be, especially in the beginning, the person to have the diagnosis, but you'll be the person who's really going to listen to them. And they like that too. So you can give them the listening. It's like, wow, I could really say, you know what? I really want to just take a moment and run this by somebody, and then let me come right back to the room. People actually appreciate that if you frame it correctly. So don't try to get it perfect. Don't have all your ducks in a row. Have all the ducks a mess. Just get in the room and start practicing. That's why it's
I
called
love that
practice.
advice.
That's why it's called
Yes.
practice. It's got to
Well,
practice.
and like I said, every single shift, I'm like, well, that's a new thing.
Well,
How
that's
about
brilliant.
that?
How about that? You
Yep.
have a what? I've never heard of this. Type. Oh, okay.
Every single
Every
shift.
day. Every day.
Yeah.
Yes.
I had to laugh a little bit because the students won't listen to this, but we have an entrepreneur series, and that's the first thing you said. You're like, I'm the Forrest Gump of starting businesses. I don't know what
Let's
I'm
just
doing.
figure
I
it
just
out.
did it.
Just do it.
Sure. I'll
Sure, we'll
start
figure
that
it out.
business.
I say yes all the time. I'm like, I don't know. I'm sure I'll figure it out. I can always come back to you later with a no.
They could, or you'll
Because
figure it out once the state goes, do
yeah,
you have this thing? Yeah,
I usually tend to, if you give me enough time, I tend to figure it out.
I like that. Um, I love that you said just listen to the patients and do a full assessment. They don't always get that
Right.
everywhere. That's your chance. Put your
Yeah.
stethoscope all over, feel
Yes.
find a liver border. They're going to tell you no one's ever done that. Yep. Well, I
Yes. They're gonna
am.
be so excited by you. Yes, exactly right.
I love that. How do people find you? Because you don't have to go to Yale or in Ohio to NP school to get
Yes,
EG prep. So this is
absolutely.
really why I asked you to talk because I really believe in what you're doing and I want all the students, just like we all in the olden days used to have a scut monkey in our pocket. Now they need EG prep.
I appreciate that. Well, first of all, you can go to NPACE and find us there. So I just want
Okay.
to surface that partnership. NPACE was one of the first um, organizations to believe in EG prep, and so I want to shout out there. So you could always find us there, and then if not, you can go to egprep.org. I think you had that right. Find
Yes.
us there, and if you just want to like hang out and just listen to my socials, I talk a lot about medical gaslighting and functional medicine. Then I'm Dr. E, the MP, the PhD. You'll find me on TikTok and Instagram and all that stuff.
And we'll be looking for the new book in
Oh yeah, you're looking
2027.
for the new book. If you're looking for my podcast, it's Medical Disruptor, but that has nothing to do with EG prep. But that's just like a different story. But
Oh, no,
yes,
I like that too. We want to be disrupting. And
yes,
well, that's how you ended up here doing this. And everyone should read your new book because as a clinician, we don't want to be medical gaslighters.
exactly right. I call myself a recovering medical gaslighter. We'll do that on another episode.
Oh, okay. I like that. We have so
Thank
many.
you.
We're going to have a secret podcast someday on
Secret podcast.
education also. So everyone be looking for that. Students, if you're out there, I'm highly encouraging you to look up Dr. E's work and EG prep. You need to learn this way. I taught for many years. I was the dean of a very big NP program. I'm telling you that this is the missing piece. You can learn diseases all day, and you should, but you have got to learn how to assess the patient in relation to what they're coming in concerned about. So thank you, Dr. E, for being here and taking
Thank
time to
you.
join us.
Thanks for
You
having
can
me.
you can find us at npace.org. And EG Prep is there. It's on our students page. We have lots of stuff. Students, we were just in Nashville. We did stitching and skin biopsies and splinting. It was actually very fun. and you can hang out with us sometime this year. We have 5 student seats per conference that are free. If you are a full-time NP student, we want to welcome you. We will not charge you. We have a form online. Find it the same place you'll find about EG prep, and you can find all things NPACE. Welcome to the profession. This is all for now with the Friends of NPACE podcast. Thank you, Dr. E, for being here again.